Okay, Chapter 11. Chapter 11 is the primary assessment, and in primary assessment, our whole purpose can be summed up in really one sentence. The intent of the primary assessment is to find and treat life threats. So if it's going to kill you right now or in the next few minutes or potentially hours, you will find that in the primary assessment, or you should. We may not always be able to do anything about it, but in most cases we have some steps that we can start to take to head off any immediate downgrading condition. So there are a few objectives in this chapter. You find those in your textbook, of course. The whole initial assessment is what we used to call it, or primary assessment as we call it. We called it many moons ago primary assessment. They changed it to initial assessment, and now they brought back the term primary assessment. So if you hear people talk of initial assessment, they're talking about the same thing. So the primary assessment should take you no more than about 60 seconds to complete. Now some people start to kind of smear the lines between primary assessment and secondary assessment. In reality, getting an accurate number for a pulse, for a respirations, and blood pressure doesn't technically even fall in here, isn't necessary. It's only necessary for you to assess that it is there and is it feel to be appropriate or seem to be appropriate. So that's what we're trying to get out of the primary assessment. Sometimes it's extremely easy. You walk in the room, the patient's looking at you, they're talking to you, they're answering questions appropriately, they're pink in color, they have a good, nice, easy respirations, and their pulse feels good. In those cases, those patients probably have a very easy to assess primary assessment, and they're obviously not in severe distress. You have a couple of multimedia videos you can look at in the you can link to from non-narrated PowerPoint, and over patient pre-hospital assessment, and then the initial assessment procedures video. Our core concepts to touch on: deciding on the approach to your primary assessment, manual stabilization of the head and neck, forming a general impression, assessing the mental status using the AVPU scale. AVPU is one of our mnemonics that we like to use in EMS. We have tons of them. Assessing the ABCs as part of our process, and then making a priority, basically how quick are we going to transport decision. So we'll start with primary assessment. So this focuses on our life threats, mostly looking at the ABCs. I also like to throw D in here. D is disability and dysfunction. It tells you a lot about what's going on with the patient's brain. Not necessarily the A, B's, and C's that kill you, but sometimes it's the D's. So, and this is going to depend on our patient's condition, our other scene resources, our on-scene resources, and then other things. So what it may be apparently life-threatening to an EMT may not be life-threatening to a paramedic. Just from years of schooling, extra, and advanced assessment techniques, a paramedic may come in and say this is not a life-threatening situation. Not to say they're always right, but sometimes it appears differently than it actually is. The order of the ABC depends on our initial impression of our patient. And in most cases, it is the ABCs, unless the patient appears to be lifeless and is pulseless. And in those cases, it switches to what we learned in CPR as the CAB approach: circulation, then airway, then breathing. But in most cases, it's airway, breathing, circulation. And occasionally, we have some immediate interventions that are needed, but in most cases, it's done nearly simultaneously with a lot of our assessment. So our primary assessment steps first are forming a general impression. So what is a general impression? This is assessing the environment, the patient's chief complaint, and their appearance, and this helps us determine that patient's severity and help us set priorities for care and transport. I think there's a better way to say this. It's called your gut instinct. Obviously, this will change the longer you're around the world of EMS. Your gut instincts will evolve with your experiences in education. But the general impression is you walk in the room, you have a quiet baby that's gray and hardly looks like it's moving. You're going to instantly get this gut instinct that this isn't good, because a one-year-old baby with all this commotion and ruckus should be screaming its head off. So you have to gather lots of different things. You look at those things that we gathered in scene size up. What scene clues did we get? What's the house look like? What's the accident scene look like? Wherever this patient actually is it filthy? Is it spotless? Is it cold? Is it hot? Does it look like they're in squalor, or is there lots of is there food? So you assess those environment things, that patient's chief complaint or what appears to be plaguing them the most, any distress that they may be in, and then their appearance. So if you're called for a cardiac arrest, that's kind of a big deal. The patient's heart is stopped, yet you walk in and the patient is looking at you and says hello when you walk in the door. That general impression, although our scene size up told us otherwise initially, until we made it inside the door to actually see the patient's face, our general impression can change. So sometimes you might walk in and think, oh, this isn't good, but yet you go over there and you do a little sternum rub, or you get down and you say, hey, are you okay, in their ear, and find out they were taking a nap. I've been on that call. Nursing home gets all excited and calls and says our patient's unresponsive, can't get them awake, and we show up and come to find out their hearing aids were out. So if you actually shake them and say, hey, wake up, they're fine. Helps us determine that patient's severity. It's not always right, but it's a good jumping off point. And I talked a moment ago about determining the patient's priority at the end of the primary assessment. Sometimes our general impression says one thing. We go through the quick primary assessment process and come to find out that isn't what we initially thought it was, and our transport priorities, our patient severities, change. Now, as you are in your general assessment mode, you should do the look test and get a feeling of the environment observations as well as a first look at the patient. That helps us form that initial general impression. Findings that indicate a critical patient. Altered mental status, these are things you're going to want to know. Altered mental status, anxiety, pale, sweaty skin, obvious trauma to the head, chest, abdomen, or pelvis, and specific positions indicating distress. Somebody having shortness of breath, propping themselves up on their arms. Basically, we call it the tripod position. They're having such a hard time, they're getting weak and tired. That's a bad sign. These are not all there is, but these are, in general, things that start to get our mind going, oh, this is potentially a critical patient. Anxiety, I like to say, not always, because sometimes we have drama queens for patients. Altered mental status, sometimes that's normal for a patient. So there's a few times in which we can't rely solely on what they're seeing here. Other things, patients that appear lifeless. So start resuscitating by beginning CPR compressions. Get your AED ready as soon as possible. Remember, the CPR is what's going to save them, and you need to work on pushing on the chest and circulating blood around before you worry about the other things. So start getting the blood moving around, gets the heart primed, gets the heart ready, and the AED will be much more likely to be successful if you've moved a little blood around through there, or the patient has recently had blood moving through there. If you're talking to the patient, they slump over, they have no pulse, by all means the AED goes on, they get shocked. But if it's been a few minutes since there's been anything, we need to get CPR going to circulate. Other things to look at: the patient's age, their sex, their position that they're in, moaning, snoring, gurgling respiration, smells of certain fumes, urine, feces, vomitus, decay. All of these things are going to play in. There's a saying that I like to use, and there is only one hard and fast rule in EMS, and that is that there are no other hard and fast rules in EMS. Really, there is not one true thing that we can say, oh, well, just on this one item alone, that completely guides the remainder of the call. Because things are weird. Some people think, oh, breathing problem. Well, does the patient always struggle to breathe a little bit? And it looks bad to us, but this is normal for them. An oxygen saturation that's low. People with chronic obstructive pulmonary disease, which is emphysema and chronic bronchitis, they always have low oxygen saturations. There's no lung sounds on one side of a patient's chest. Well, normally we'd think that's kind of bad, but you can live without a lung. Sometimes patients have lung cancer, they take a lung out, and that patient does just fine. So there's not just these single points in most cases. So the chief complaint. Why did they call us? Sometimes it's specific, abdominal pain, sometimes it's vague. A lot of times we get vague. I don't feel good, I'm sick, called for a sick party, called for an altered mental status. Well, what does altered mental status mean? Well, they're anxious. Well, that's technically an altered mental status. Or they're unconscious. Now, that's definitely an altered mental status. Sometimes we really have to fight to get something out of them. And so sometimes we just end up having to ask the patient, why did you call us today? What's the major issue that you called us for today? Okay. You might have gotten called for back pain. Okay. How long have you had back pain? For 4 years. Why did you call EMS today? What made it different today that you decided you needed to call EMS? You need to state it something like that. What's different today that made you want to call EMS? Because there's probably something that changed. It's worse than it normally is. I'm weak and tired. I can't feel my feet. So we have to kind of go and do a little bit more digging to go with our chief complaints. We assess the mental status. This is a must know. There are 4 mental statuses you can have: alert, verbal response, painful response, or unresponsive. Note there is no semi-conscious, partially unresponsive, semi-responsive. None of those exist. There are 4: alert, verbal, painful, and unresponsive. So what does this mean? Alert means they're looking at you. There may not be anybody home, but they're looking at you. That's alert. So they may not be oriented to what's going on, but when you walk in the room, they kind of turn and look at you. Maybe it's even with a blank stare. We document their orientation. This is going to be different from place to place you go, but it's fairly common to determine whether they are oriented to person, place, and time. Some places will also throw other things in. They'll ask who's the president, what is your location, where are you at right now. It all depends on the system. But person, place, and time are all things that people should have a pretty good idea. So a person, what is your name? Hopefully they know that. Where are you at right now? And what time of the day do you think it is? What time of the day is kind of a can be a tricky one, because if you're not looking specifically at a watch or something, a clock, you may not know specifically. So what I generally use, will ask them the general time span. Is it morning? Is it around noon? Is it afternoon, evening, nighttime? Also remember, if you have a big clock hanging on the back wall of the ambulance and you ask the patient, what time do you think it is? They're going to look at the clock. Or if they want to look down at their watch or their phone. So you may need to say this, without looking, can you tell me about what time it is? If they're not kind of aware of your coming into the room, then you need to determine what makes them aware of you. So verbal response. If you get down and say something to them, hey, can you hear me? Can you talk to me? Are you okay? Can you wake up and talk to us? If speaking to them, and sometimes you have to be a little loud, but in most cases, start out with just a general normal voice, normal tone. Hey, are you okay? What's going on? Can you wake up and talk to me? If they wake up and start discussing, or at least are aware of you at that point, then we say they have a verbal response. If that doesn't work, then we need to inflict some sort of a painful response on them. Now, this is not, elbows drop into their forehead. This is usually something like taking your knuckles and rubbing it hard on their sternum, pinching them a little bit. You can put something between their fingers, right down all the way to the bottom, right, the webbing between the two fingers, but like a pen light in between there, and pinch the fingers together. Something like that creates a little, actually annoying more than anything, response or stimulus. And if they awake and they kind of at least come up for a little bit, and even if they may drift right back off, that's considered painful. If they respond to nothing, then they are unresponsive. So after we've determined that, the order of our primary assessment obviously varies, like I mentioned, with airway, breathing, circulation. Note that in the picture we have them doing a head tilt chin lift. If you have a patient that's not alert and looking right at you, you may need to stop and take a moment to decide, which direction am I going with this? And that really is based off of what you got from your from your scene size up. If you gathered that this is probably a trauma patient, maybe they've fallen, maybe they've been ejected from a car, and in some instances had some sort of a blunt or penetrating trauma near their head and neck or spine, you need to take C-spine precautions, and with that includes, how are you going to open their airway? We talked about in the Airway chapter that we have two major ways to do this. The most common way for medical patients is the head tilt chin lift, or for trauma patients it is the modified jaw thrust. So with the airway, if it is not open or it is endangered, take measures to open it, like I mentioned, with the appropriate method. If you're having to do the jaw thrust, remember you have to maintain that jaw thrust and you have to hold their head in a neutral position. Breathing, we assess their breathing. If they don't have any breathing, or their breathing is basically minimal, we have to do something for them, and we have to ventilate them, usually using either a bag valve mask, a pocket mask, something along those lines. In respiratory arrest, that is no breathing. Remember, the medical term for this is apnea, and that respiratory arrest requires us to work rather quickly to reestablish some breathing. If they're not alert and they have inadequate breathing, some alertness and inadequate breathing, or adequate breathing but signs suggesting respiratory distress or hypoxia, we have to kind of stop and assess the situation. Sometimes they'll be alert but breathing 40 times a minute as an adult. For a baby, that's normal. 40 times a minute for an adult is not good. That patient's not in good shape. So we may have to try to start to breathe for that patient to assist them. If they're breathing okay but still appear to have some hypoxia or some signs of inadequate oxygen levels, we may want to consider putting oxygen on them, whether we use a non-rebreather or a nasal cannula. Usually we base that off of our pulse oximetry. If you have it at hand and you can slap that on, then you can start that treatment. So oxygen, airway, we did maybe some suctioning, maybe some head tilt chin lift, maybe put in an oral or nasal airway. Breathing, we either started ventilating them or we provided them some oxygen. Circulation, we go for a pulse. Remember, on a conscious person, in most cases a conscious adult, we're going to assess the radial pulse, or on an infant, we'll check it in the brachial pulse. On the unresponsive adult, we will go to the carotid artery, or the carotid pulse in the neck. What we're really looking for is assessing the rate, rhythm, and quality of the pulse. So, does it feel quick or slow or normal? Does it feel strong or weak or normal? And strong would be bounding, weak is generally thready as long as it's fast. And then, does it feel regular or irregular? That's really all we need to gather out of that. We will get a formal number eventually. Now, if you have extra sets of hands and somebody else can be getting an actual set, great. Get the set of vitals as soon as possible. Secondly, under circulation, we're assessing their skin. We're looking for three things: color, moisture, and temperature. So in most cases, the color is going to be pinkish. Depending on that person's ethnicity, that may be slightly different, of course. And in those cases, if they're a person of color, particularly darker skin tones, we're going to look in their mouth, look at their tongue and their cheeks. That's one of the best places for us to find, inside their cheeks, I should say. That's one of the best places to assess that skin color in this person. Is it dry? Is the skin particularly dry? Are they sweaty? They may be diaphoretic, which is hot and wet, or they could be clammy, which is cold and wet, or cool and wet. And then temperature. Do they feel warm to the touch, cool to the touch, hot, cold? This is a difficult one to assess as well, because sometimes we came in from an environment that was a different temperature than the patient's been in for a while, and they're not going to feel quite right to us. Assess the bleeding. Is there any bleeding? And when I say is there any bleeding, a little bit of bleeding is okay. We'll get to that. We'll deal with it. Excessive bleeding, spraying out, rushing, gushing out very quickly is stuff that needs to be taken care of right now. If we don't do anything about it, they bleed to death. So under circulation, we may do CPR. We may get our AEDs ready. We may do a little shock treatment, which would include covering them up, keeping them warm, giving them some oxygen, which we did in breathing, and then controlling any bleeding. So if we need to put a dressing on something and hold direct pressure, start working our way towards a tourniquet, that's treatments we would do in circulation. So I said about the assessment of the pulse, so within normal limits, too fast, too slow. Should also assess the regularity and the strength of it. Assessing the skin, is it pink, is it warm, is it dry, or is it clammy, is it diaphoretic, is it pale, is it cyanotic, which is blue skin tone, is it mottled? Mottled is a kind of looks like marbled, so they kind of have some reddish splotches and some white splotches. Looks like marbling, or almost like Colby Jack cheese. Immediate interventions for circulation, obviously your CPR, AEDs. If we don't have to go there, the bleeding control. So the final step here, determining patient priority. Now, You might be going, well, what happened to D? You talked about D. What happened to D? Well, D was the assessing their AVPU. There are a couple of things that often will get thrown in there as well. Is, how oriented are they, and can they move their arms and legs appropriately? Those are just real quick little things that can be checked. So our final step is determining a patient's priority for transport. Do we need to transport quickly, or do we have a few minutes to do a better assessment and do some treatments before we go ahead and start transport? Not all patients, in fact most patients that we deal with, do not need immediate transport. They benefit from us sticking around a couple minutes to splint their arm, or to put a backboard on, or to assist them take one of their breathing medications. Those patients generally do not need immediate transport. So we basically are going to determine our patient to either be stable, which our assessment findings, I don't like when they throw vital signs in there, their assessment findings are within their normal range. Potentially unstable, just from knowing what we know, seeing the big picture, even though their vital signs are maybe okay at the moment, we're going to say, they're potentially unstable. They could go south really quickly. Or they're unstable. They have immediate threats to their ABCs and Ds. They are not doing well, and they need to get to the hospital as soon as possible. So need for priority transport. This is initiating priority transport if a life threat problem cannot be controlled or threatens to reoccur. Remember, this isn't only just something that we quickly fix. Maybe they're short of breath. Well, you come to find out they're on home oxygen and their oxygen was turned off, or it was unhooked. We hook it back up. Now all of a sudden things are getting better. Probably don't need a priority transport. Maybe they're still going to go to the hospital. You probably don't need immediate transport. We get there and the patient has some slightly altered mental status, and they had gotten something to eat just before we got there. Now all of a sudden, 5 minutes into this, they're completely alert and conscious and oriented. So not always. And then continue to assess that patient en route. We're going to reassess these primary assessment items at least every 15 minutes on stable patients, or 5 minutes on unstable patients. You can go more often if you'd wish. Just don't go any further out if you can avoid it. And we're going to couple some other assessment findings in there after we learn those, but that's how often we do a reassessment. So why must we continue to reevaluate the primary assessment? People change for the better and for the worse. So once we commit to one particular paradigm in doing our patient assessment, doesn't mean that we're stuck on that. That initial field impression can change. So as things change, we change our treatment, we change our transport. All right, so there's a video for you, a couple of videos. So patient characteristics and the primary assessment, so some things that we can kind of gather from all this. So patient characteristics determine the form of an assessment that we're going to take after this. So is it a medical versus a trauma patient? Do we have an altered mental status, or do we have somebody who is alert and oriented? Do we have a child, or do we have an adult? These things will alter the approach that we take with our patient. So pediatric note, adjust the assessment to social and physiologic norms of children. We've kind of talked about that as far as the human growth and development that we learned back in section 1. We know that in general, pulses get slower, respirations get slower, blood pressures get higher as we age. So I don't expect anybody to be able to immediately recite what the normal vital signs for a 7-year-old child would be. So use your resources. A lot of ambulances have a little cheat sheet, and that's fine. Throw your little laminated cheat sheet in your assessment kit. So you can go, oh no, those are about right. We know that newborn babies generally have pulses of 140 to 160-ish. Respiratories are somewhere in the 40 to 50 range, and blood pressures down in around the 70 millimeters of mercury systolic, or top number. And they generally, as they age, will get closer to adulthood, where your typical adult heart rate is somewhere in the 60 to 100 range. Your normal adult respiratory rate is about 12 to 20, and your normal adult blood pressure is somewhere around 120/80. So how might your normal findings in the primary assessment differ for a child compared to that of an adult? Patients are all different. So if we have a child that is acting quiet and shy and reserved, it may just simply be because of the situation they're in. It's very uncomfortable and unfamiliar. Whereas, in most cases, quiet children are sick children. Whereas an adult who's maybe not saying a whole lot, that may just simply be the way that they are. A blood pressure, a heart rate of 120 in a child is not going to be terribly concerning. Where in an adult, we're going to kind of take a little more notice. So steps of primary assessment. Despite the patient characteristics, follow the primary assessment steps systematically. This is your first exposure to patient assessment. I cannot emphasize enough. Pick a way to do it, stick with that, and always do it the same way. So once you find your groove, that's the way you always do it. And when it comes to testing purposes, you'll be able, if you have that committed to memory, you'll zip right down it and you'll do just fine. So you get your general assessment, you check the mental status, the ABCs, and then make that priority transport decision. So our chapter review. Primary assessment is a systematic approach to find and treat life threats. That general impression, although subjective, can provide extremely useful information regarding the urgency of the patient's condition. So we throw this term subjective in there. Subjective means it came from a subject, and you are the subject that made that. So it means your view is just one view. If we work in teams and pairs, we can compare our subjective general impressions and say, oh, this is good, or oh, this is not so good. Maybe somebody saw something everybody else didn't see, and that altered the way that they made their general impression. And if that's the case, you guys chat about it. Maybe it's enough of a difference that you make a big change in the way you handle things, transport or certain treatments. Determine the mental status following the AVPU approach. The AVPU is very, very familiar to EMS, and there are other healthcare professions that are pretty familiar with AVPU. The good thing about AVPU is if we use the actual term that goes with the letter, alert, verbal, painful, or unresponsive, almost everybody can figure out exactly what we're talking about just simply from the actual wording. We're going to evaluate the airway, the breathing, the circulation. It's going to be quick, but very thorough, and it will reveal any immediate life threat that can be treated before further assessment. Patient's priority describes how urgent that patient need is to be transported and how we're going to conduct the rest of our assessment. If we're going to do a real quick head-to-toe survey, or if we're going to take the time and go inch by inch and look here and there. Are we going to concentrate on that patient's history, or are we going to look more at this patient's body? Determine if that patient's problem is medical or traumatic. Determine if they're responsive or unresponsive, an adult, a child, or an infant. And then rapidly identify the need for immediate airway interventions. whether that is manual things, adjuncts, suction, oxygen, bag valve mask. Determine the patient's condition is stable enough to allow for further assessment treatment on scene. Remember, most patients do not immediately need to be whisked off to the hospital. We have a few minutes. So what factors will you take into account when forming a general impression of the patient? How should you assess the patient's mental status with regard to AVPU levels of responsiveness? How should you assess airway, breathing, and circulation during primary assessment? And what is meant by priority decision? So you have a middle-aged male lying on the street after being hit by a car. He appears unresponsive as you approach. You notice that he is bleeding from laceration on his forearm and making gurgling sounds from his airway. If you are alone, what factors do you consider on deciding what to do first and why? So with that being said, we say a middle-aged man lying on the street after being hit by a car appears unresponsive as you approach. You notice that he's bleeding from laceration on his forearm and making gurgling sounds from his airway. So he's an adult, male, unresponsive, trauma patient, breathing difficulties, and he has some bleeding from a laceration. So a few things that come to mind here. Number one, an unresponsive trauma patient. He's a critical, severe trauma patient. Breathing is an issue when you have gurgling respirations. If he has gurgling respirations, we need to do something about that. Otherwise, the bleeding really doesn't matter. After we do some airway maintenance, whether we do probably a jaw thrust, probably we'll get an oral airway since he's unresponsive. Suctioning, of course, suctioning will be huge. Holding his head in a neutral inline position, although it could be difficult for us to do if we're alone, and at least until somebody else shows up or we can grab a hold of a bystander. And then the bleeding control, as we get extra hands, we can work on the bleeding control provided that it isn't severe and spurting or running rapidly out. They don't make mention of exactly how bad the bleeding is, so we would have to assess that on a case-by-case basis and say, does this appear that it's just kind of general normal venous bleeding, or is it spraying and spurting like an artery?